Patients who have undergone trabeculectomy few years back and maybe have been using some anti-glaucoma medications including pilocarpine usually have a unique situation when they opt for the cataract surgery, and it poses a problem for the surgeon. Here we have a patient who had undergone trabeculectomy about 20 years back, and here we can see there's a large peripheral iridectomy and a pupil which is bound down and having 360-degree posterior synechia and a filtering bleb. Now these cataracts are usually fairly advanced and the pupil is just not dilating, and this poses a surgical challenge. This is the fundus photograph of the same patient showing some amount of haze due to the cataract, and I will also reveal one finding which I have observed in these cases is that usually the steep axis lies right along the position of the filtering bleb. So that is the point where it is best suited to make an incision, and mind it that clear corneal incisions are the best choice here because they don't disturb the filtering bleb at all, so that the functioning of the bleb is retained, and the area where the iridectomy has been done will also facilitate because these patients will have a shallow chamber and a non-dilating pupil. Here we will see how we are going to manage these two issues. This is a slightly deep set eyes, so we have some amount of pooling, and this can be taken care by adjusting the drape which is self-adhesing, and we should see that there is nothing which is hindering the flow of fluid. Putting viscoelastic gel into anterior chamber, and we can notice that there is hardly any depth. In spite of forceful filling of the viscoelastic, the anterior chamber doesn't deepen. So what is the solution? Making the side port so that we have access for the side port instrument, and then what can be done is you tap some vitreous. Now this has to be done carefully at a point where there is no possibility of damage to the retina or zonules, because these are the important structures which are lying across this area, and this lies at about 3.5 to 4 millimeter from limbus. And once we have removed something like 0.5 ml of vitreous fluid, we can see that this is about 0.5 ml of vitreous fluid, and subsequently when we will put in viscoelastic gel, we'll observe now this time the anterior chamber deepens, and this is crucial to have some space in the anterior chamber. Proceeding to remove this pupillary membrane, which can be identified in form of a white fibrous plaque adhering to the pupillary border, and one can simply hold it and pull it away from the border, and one will find that it will simply get peeled away from the pupillary border, and the pupil gets released, and subsequently it will dilate better. There will be some release of pigment along with this fibrous tissue, and that is not a worry. Completely removing this membrane so that we have a pupil which is functional and which can be dilated well, and this pupil could have been stretched also, and that could have served the same purpose, but that would not have facilitated removal of this membrane. Now once this pupil is free of this fibrous band, we can again go ahead and deepen the anterior chamber, and we will see that the pupil will dilate slightly. Now this is the point where one has to take decision if we want to use pupillary expansion devices, or we can proceed just like that. So here I am proceeding without any pupillary expansion devices, because I find that I can be comfortable doing phacoemulsification in this amount of pupil size. Going ahead with the phacoemulsification, and the proposed technique would be the direct horizontal chop using a micro flare tip, and we will be placing a Nagahara chopper or the blunt chopper, and this will provide us enough leverage so that we can crack this nucleus efficiently, and this seems like a grade 3 to grade 5 nucleus, and burying the tip so that we have good purchase, and applying some amount of power again once we have placed our chopper so that we can travel across, And one thing you will observe is that the chopper is not only aiding in chopping the nucleus, but it is also allowing us a better view, because the shaft of the chopper will simply stretch the pupil and provide us some facility in the view. A primary crack has been created and the nucleus is being rotated, and I believe that creating multiple small pieces is a better strategy rather than having a 4 quadrant technique. In the nucleus which are large and bulky, it is better to remove one of the wedges which you have created, and this will create enough space for subsequent manipulation. So we will remove this wedge, which will allow us some space in the bag, so that without stressing the zonules we can manipulate the nuclear pieces. Now this facilitates some space, and subsequently we keep on rotating this nucleus and bringing up the intact part of the nucleus, so as to we have enough material in front of the phaco tip so as to bury and then perform a horizontal chop. Holding the nucleus, performing a chop so that the pieces is broken into smaller pieces, and this has to be continued till you have small pieces which can be simply emulsified using phaco power. So repeat this process till we have chopped till the end or the other side of the nucleus is reached. This patient was little uncooperative in the sense that she had a tendency to move the head to one side, so that is why I have to repeatedly correct the head position. Now this is important because once the patient tilts the head towards the other side, there is some amount of pulling which starts happening, and this pulling will compromise the view. So it's important to keep an eye on these movements of the patient. Once we have chopped the pieces into smaller pieces which are adequate to fit into our phaco tip, we simply proceed for emulsifying and removing these pieces using the phaco power. And as we can see, the pieces are small, and maybe that I have chopped this nucleus into more than 6 or 7 pieces. The key element is that the phaco power has to be delivered in the center so that none of the iris tissue is touched, the pupil is not aspirated, and this will be aided by the side port instrument, which has to do more maneuvers when compared to the main phaco tip. Keep on looking for the pieces and manipulating with your phaco second hand instrument, which can be used to bring up the pieces up to the phaco tip. And this is an efficient strategy, because instead of moving the tip, which has not only aspirating power but also emulsifying power, which will damage the iris tissue if it touches the iris when the phaco power is on. So central safe zone is the area where you would like to keep your phaco tip, and the second hand instrument can always bring these pieces and align them so as to get them consumed by the phaco power. The pieces have to be reoriented so that the bulk part of the nucleus is presented at the tip. And we can see that this is the last piece which is being consumed here. And now we have some amount of flimsy cortex which is hidden behind the iris in the fornices of the capsular bag. Proceeding for removing this cortex, and this cortex cannot be removed without peeking behind the iris, so one has to use a dialer, a chopper, which can be used to manipulate the iris so that we can pull the iris to periphery or push it to periphery and then visualize the cortex behind it. Now this is a T-shaped iris, T-shaped dialer, which is little bulkier, so I have decided not to use it and just go ahead and use a simple chopper which I was using during the phaco emulsification. Now using this configuration, using the hook-like configuration of this chopper, we can pull the iris towards the incision and also manipulate so that we can lift the iris and push it little away from the site where you want to visualize. One has to have very good control of the foot switch, because you want to constantly modulate your aspiration flow so that when you are close to the posterior capsule or iris, You want to reduce the aspiration flow. When you are away and also aspirating a bulk of the nucleus, bulk of the cortex, you simply go ahead and put more vacuum and flow rate for aspirating these pieces. Mind it that I am using a machine which is Venturi based, so the flow cannot be controlled independently, and vacuum and the bore size of the aspiration port will decide the amount of flow. One has to mentally register and keep track of if any portion or any quadrant has been left behind, and reach underneath the iris and aspirate. Subincisional area is a especially vulnerable area, and one has to be very careful when removing cortical matter from this area. Good view and good foot control is the key. Infusion has to be remained on all the time, and the irrigating ports have to be inside the anterior chamber. Whole of the cortex has been removed well, and now proceeding on to implanting a hydrophobic monofocal IOL single piece, and at this moment the camera is little off center because of the constant movement by the patient. However, the IOL goes into the bag and now it has to be dialed in position. A few tips which one can learn from this surgery is that post-trabeclectomy patients have a small pupil which doesn't dilate very well, so you have to be prepared for that. The anterior chamber is very shallow, and we can always use some vitreous tap to provide space so that the iris lens diaphragm can move little backwards, providing us space in the anterior chamber. And then judicious use of vacuum and flow rate, and also manipulating the iris to remove that portion of the cortex or the nucleus which is hidden behind. Use of pupillary expansion devices is optional. If you can manage without them, it is well and good. If you need them, you will have to make some more manipulation and investment on the part of the patient. Here we can see the wound is little leaky, especially the side port. So I am deciding to hydrate the side port. And because the surgery is being done under topical anesthesia, so patient is retaining the movements. However, now the chamber is sealed, the surgery is done. This is the post-op day 1 picture, which shows a clear cornea and an incision size and a bleb which is still there, which has not been disturbed. Thank you.